Hello, my name is Dr. Richard Chanik, and it's a pleasure to be joined by my colleagues Dr. Victor Tapson and Dr. Rajan Sagar to discuss really a revised definition for pulmonary hypertension that's emanated from the most recent World Symposium on Pulmonary Hypertension. We're now defining pulmonary hypertension as a mean pulmonary artery pressure between 20 and 24 millimeters of mercury. In that group, which previously was considered non-pulmonary hypertension or even pre-pulmonary hypertension, we're now defining that group as having true pulmonary hypertension. So I would like to get my colleagues' impressions of this. Vic, starting with you, why are we now using 20 as a cutoff for pulmonary hypertension? Why this change?
Well, I have to say, Rich, I had a little trouble grappling with this at first because we've had in all of our clinical trials, it's ingrained in us, mean PA pressure at 25 is the cutoff. When I think about the study that Kovacs and colleagues did, our Austrian colleagues, they published normal patients, right heart caths, 1,187 patients, and looking at what was normal. And in fact, the mean PA pressure in this study was 14. So you look at two standard deviations above that. That's a 97.5 percentile. That's 20. You look at one standard deviation above, that's even 17. So to me, when I think about that, normal PA pressure being in the 14 range, maybe a little higher, I can accept 20. It's still a bit arbitrary, but that's kind of where this number came from and why we've decided that maybe we should lower the number from 25 to 20 to 24.
Yeah, and I know there was some concern about potentially not diagnosing true precapillary pulmonary hypertension using this. And so there are other components to the, quote, definition of precapillary pH. Could you tell us?
Absolutely. So we've got to look at the PVR too, right? We can't just look, because there's other reasons. You have high output states, various things. You got to look at the PVR should be greater than 3. So you've got a mean PA pressure 20 to 24. If the PVR is greater than 3, then you've got pulmonary hypertension.
And then using the sort of standard wedge cutoff for pre versus post.
Sure, exactly. The wedge pressure of 15 still holds.
Now, Rajan, the role of exercise testing in unmasking or bringing out pulmonary hypertension, historically in this group of patients in that sort of 20 to 24 range, we'd often do exercise hemodynamics to look for an abnormal response. Is there still a role? Where do you think the role is of exercise hemodynamics in let's say, these, quote, mild patients?
Well, I think we have to step back and kind of look at the patient we're talking about. These are presumably symptomatic patients, unexplained dyspnea, and we're really trying to find out why they have that symptom. And you're right, traditionally, when we saw some of these patients in this 20 to 24 or 21 to 24 millimeters of mercury range, our thought was, well, if they're having unexplained dyspnea on exertion, perhaps if we exercise them, we would be able to unmask, if you will, an abnormal exercise response, and then even consider therapies. Sometimes in some of these high-risk populations, scleroderma comes to mind, and this is the type of patient that we're usually talking about. Presumably, exercise can be used in this context, and the question now, of course, is, should we be now exercising patients, perhaps, as Dr. Tapson just said, patients who are now lower than 20 millimeters of mercury, if they in fact if we have a heart catheterization at rest showing their mean pressure, PA pressure is 17 or 18, should we be thinking, now of exercising those patients if in fact they have a symptom that's unexplained? But of course, as we all know, exercise in terms of a definition, we're still trying to establish that. So it's a little bit twice removed, if you will, from any type of consensus statement or any kind of definitive comment on how we should act or work up these patients.
You talked about sort of high-risk populations. Is that, Vic, how you look at it? If you look in this 20 to 24 range, the question is going to be what you do with these patients. And sure. I think we'll talk about treatment in a second, but are there certain patients in that range that you would follow more closely or really pay attention to, or all of them?
I think so. I think in the olden days, we thought when someone had PA pressure less than 25, but they were symptomatic and were suspecting something, we would, like Raj said, we either exercise them or we'd say you don't have pH, maybe we'll check you again in 3 months or something like that. I do think we're going to run into patients that are going to develop worsening pH or have exercise-induced pH. So I think you look at the whole picture, look at the patient, their symptoms, their phenotype. If this is an 80-year-old patient with diastolic dysfunction, that kind of patient, right heart cath, is probably going to convince us based on their wedge and LVP that this is not PAH, but it still may be pH. We're going to look at everything, their symptoms, their exam, their echo data, their BNP, their walk distance, put these things together and make a plan, and generally, at the very least, follow them up. If not, exercise them and see if we can bring out something.
Yeah, and that leads us sort of to the next sort of elephant in the room, I guess you'd say, is should these people be treated? And that, I know, is a controversy at the World Symposium, that the concern that redefining pH would lead to over-treatment in a group of patients that hadn't maybe previously been treated. What is, I know it's a very broad question, but what is your overall view of treatment for this subgroup of patients?
I think in a nutshell, Rich, we're going to treat some of them. I think we're going to do it. I think we're going to want to do that cautiously. We'll introduce now, I don't think we'll use, for example, the upfront combination therapy approach for many of these folks. We might try one drug, and there's no definite single drug you'd use here. A PDE5 inhibitor might be the easiest thing to do in some of these folks, but I think we're going to treat some. We're going to pick them carefully, screen them, individualize them, treat them, and then of course follow them up. I think someone like that I'd want to follow up no later than 3 months, at least for the first time. They're on a new drug, got borderline pH, if you will. If someone is more symptomatic, I see them sooner, less symptomatic, I might wait longer, but I think the real key here is you can't really go long if you follow someone up closely.
And how, I guess, as Rajan, I mean, whether you agree or not, but how would you answer the counter argument that these patients just haven't been studied in any randomized trials? They would have been excluded from the trials. Is that a counter argument against treatment, or not?
No, I think it's a valid point. We certainly have very little data in this, or very little data or no data in this population, but we do have some data. And I think in the high-risk scleroderma population, same authors, the Kovacs and the Austrians have done a really nice job of looking at this population. And interestingly enough, when you look at the borderline cases, or what we've called borderline in the past, 21 to 24 millimeters of mercury mean PA pressure, these patients do appear to have abnormal exercise responses, so suggesting that could in fact be playing a role in their symptoms. But interestingly enough, there's a nice article that's come out in the last year following these patients over time, sort of trying to determine how many of them actually develop resting pulmonary hypertension, which of course I think is what the fear is. The fear is that, hey, are we going to catch a disease earlier, and can we treat them earlier and avoid progression of disease? And I think what they showed pretty nicely in this group was that very few, if any, actually developed resting pulmonary arterial hypertension.
So maybe, so then I guess it gets to the same question of, with treatment, what would that change?
Correct, and the natural history is one that's perhaps not predictable.
I think we'll agree that, to really study these people properly, we need to do sort of prospective randomized trials. It's a tough group to study, but a very interesting group because it's a fairly large group. I think that's all the time we have for this segment. Thank you very much.